I'm going to be talking to you today about prioritizing resource allocation in COVID-19's potentially devastating aftermath. This doesn't have to do 100% with global surgery, but given the fact that COVID-19, the pandemic, the lockdown has affected every aspect of our society, there will be consequences for surgical services as well as in terms of demand as well as supply with regards to what surgeries can actually be delivered for citizens in your country. So I'm going to start off by looking at lessons from the 2008 global financial collapse. And the reason I'm doing this is because we need to prepare ourselves for a very tough road ahead. And some of these things are already coming to the fore, but we're going to see things get probably worse as time goes on. So the 2008 global financial collapse led to a global economic downturn. And you can think, well, that's the economy. What does that have to do with anything else? But when you look at health outcomes, and I'll get to this later, 80% of health outcomes are due to what's termed social determinants of health. So access to jobs, education, housing, transport, et cetera, et cetera. Only 20% of health outcomes are due to access to clinical care. And the 2008 global financial collapse had a severe effect on the economy, and that had trickle-down effects on all aspects of our lives. And mental health as well as physical health were severely impacted because of the 2008 global financial collapse. And one demographic that was particularly hard hit was the youthful demographic. And some of the impacts are such that they'll have transgenerational effects. Obviously, the child is going to carry some of those effects with them throughout their lives. If they're given the opportunities, then they can overcome some of the negative impacts of, for example, the 2008 global financial collapse. But if they are not, then oftentimes they might end up getting into a poverty trap, and they won't be able to escape and get back to the level of potential that they had pre-collapse. Now, the reason for this is because we're living and working and breathing in complex and non-linear systems. And a key characteristic of any complex or non-linear system, or two key characteristics. One is they're unpredictable, and number two, they're irreversible. And so what we kind of know from the 2008 global financial collapse is that the recovery won't be quick and it won't be predictable. It took us until 2012 to recover economically from the 2008 global financial collapse. And as mentioned, some of the people who were the most severely affected by the 2008 global financial collapse were not able to recover at all. Now, why is this? There's this concept in complex nonlinear systems called hysteresis, which basically means that you have a system that's unpredictable and irreversible. So you can see at the bottom, you have the pre-COVID state, and it's fairly stable. It doesn't mean that it's equal, but it's stable. And then you have COVID-19, which is this period of instability, which just shifts things all over the place. And that you could also see as the 2008 global financial collapse. It had changes on our society that we weren't able to predict, number one. And number two, we're not going to be able to predict the consequences of those changes. And that leads us into the post-COVID state, which is going to be stable as well. It will take us a while to reach that level of stability, but it will be different from the pre-COVID state, and we will not be able to reverse it to the pre-COVID state because some of the changes that will have occurred will be irreversible. And you guys have probably seen these complex network diagrams where you have one node related to so many other different things, and it's these complex systems that we're just not going to be able to predict, and we're not going to have an idea of how one element of the system being impacted is going to have add-on effects to other elements of the system. This is the so-called butterfly effect. So how do you make decisions in these complex nonlinear systems that are unpredictable and irreversible? Because you have to make decisions as clinicians, as surgeons, as people working in global surgery. You will have to make a decision. And this is where this conceptualization of risk versus fundamental uncertainty comes in. So this is the work of Gerd Gigerenzer, who's at the Max Planck Institute in Berlin. And he basically divides up decision-making into situations of risk versus situations of fundamental uncertainty. In a situation of risk, you know how different variables interact. And so you know the outcomes as well as the probability of each of the outcomes. In a situation of fundamental uncertainty, you know some of the alternatives and some of the outcomes, but you largely have no idea how the different variables interact, and you also don't know all of the alternatives, you don't know all the outcomes, and you don't know what the probabilities are for each of these different alternatives and outcomes. And so a question that you can ask yourself in a situation of fundamental uncertainty, which is what we're in with the COVID-19 aftermath, is what do we actually know? And you can create a simple matrix in your head where you have knowns and unknowns. And you have your known knowns, you have your known unknowns, and you have your unknown unknowns. Okay, so what does that actually mean? So a known known can be reduced down to risk. So for example, the number of people in ICU with COVID-19. The number of people in ICU with COVID-19 who have recovered or died, the number of people in your society or your community claiming unemployment, the number of people needing housing benefits. The known unknown can be reduced to risk with data and research. So, for example, the total number of infected people in your population. That can be reduced to risk by having a systematic testing strategy. The total number of people with immunity. Well, a prerequisite for that is ensuring that you actually have a valid antibody test. And once you have that, then you can test the population. When will the second wave hit? We know that the second wave is going to hit, but we don't know when. What are the total number of unemployed in your population? What are the total number of people going hungry in your population? And then there's the unknown unknowns. And so these are the situations of fundamental uncertainty. They're not risk, they're fundamental uncertainty. You move one little piece and it has massive dramatic consequences for the entire system. In a situation of fundamental uncertainty, your best bet is to take as simple of an approach as possible so that you can control what you're doing and you can also control the outcome measures that you can attribute to your actions. So, as Gigerenzer advises, as you do not fight fire with fire, you do not fight complexity with complexity. And what he's really referring to here is this sort of obsession that we have nowadays with big data and AI and machine learning, and we have this notion that if we have enough data, we will be able to solve these problems. Data is necessary but not sufficient because you need to know how the variables that are represented by that data actually interact. If you do not have that knowledge, then you will not be able to predict how the different variables interact. And what you'll do is give yourself a false sense of security, and you'll fall into the trap of what's called overfitting. So, with all of that being there for you guys to digest, how do we actually adapt to COVID-19's aftermath, and how should we prioritize allocation of our resources, whether that resource be our clinical staff, the use of space, i.e. hospital beds, etc., and other resources, financial and otherwise, housing, education, transportation resources, etc. So as I alluded to earlier on in the talk, if you look at health outcomes, which you can sort of disaggregate into these two factors, length of life and quality of life, and it's debatable as to whether length of life should be 50%. I mean, there are debates about this, but it's something that we can at least use as a starting point for a quantifiable metric that we can use. And if you look at health outcomes from this perspective, only 20% of health outcomes are due to access to clinical care, which means access to doctors and hospitals and nurses and medications. 80% are due to health behaviors like tobacco use, diet and exercise, etc. social and economic factors like education, employment, income, etc., and physical environment, air and water quality, as well as housing and transit. And what we're seeing already during the lockdown was an increase in social need. And what we're probably going to see, unfortunately, is an even more dramatic increase in social need in COVID-19's aftermath, similar to what we saw from the 2008 global financial collapse. But my assumption is that COVID-19's aftermath is going to be much worse because it's affected every aspect of society because of the economic lockdown. And these are just some headlines taken from England. So educational inequalities are increasing. Jobless claims have jumped to the highest since 1996. Vulnerability to food insecurity increased dramatically. So during the lockdown, 3 million people went hungry. Problem drinking is soaring. There's an increase in domestic violence, and domestic abuse killings have more than doubled during the COVID-19 lockdown. And so, again, when you're thinking about how you prioritize the allocation of your resources, your finite, limited resources, one question you can ask yourselves when you're designing this response for your communities or your organization is, what will cause your citizens to suffer the most? And again, if we go back to this notion of social determinants of health and 80% of health outcomes being due to these social factors, and we take in some of the work from Wilkinson and Marmot, what we find is that educational failure, job insecurity and unemployment, and housing standards are three of the biggest things that will impact your citizens and will have the biggest impact on their levels of suffering. And sort of overlaid onto that, stress, social exclusion, social support, addictions, food, access to just nutritious food, and transportation. And when you're thinking again about the health of your populations, it's important that we make a distinction between a high-risk approach, again, we're coming back to this notion of risk versus fundamental uncertainty, versus a population approach. A population approach tries to control the causes of incidence of disease. So for any healthcare system, you will have supply-side constraints and demand-side constraints. So supply side is, how many surgeons do you have? How many nurses do you have? How many operating theaters do you have? And a demand side constraint is, how many people in your population do you actually need? Or how many people in your population actually need surgery? Okay? And a great example that I've heard is in some sub-Saharan African countries, there's a huge incidence of electrical burns. And you dig a little bit deeper. Why are these people getting electrical burns? Well, it's because they have exposed electrical wires. Well, what can we do about that? Well, one is we can get more surgeons trained, more trauma surgeons trained, so these individuals who have these electrical burns can actually get treated efficiently and effectively. The other thing is we can create a policy recommendation which dramatically fines any organization or company or building that has exposed electrical wires. So rather than trying to create more surgical beds and more doctors who are capable of dealing with these individuals who have electrical burns, let's control the cause of incidence and reduce demand. And Geoffrey Rose created this very simple heuristic where if you look at the risk of your population on the x-axis, you have low risk, medium risk, high risk. And if you look at most healthcare systems, most of them focus on the high-risk populations because they're high risk. But if you look at aggregate morbidity, mortality, and spend, it's always in the medium risk group. Because though the lower relative risk, there's a higher absolute number of individuals in that group. So the number of events in that medium risk category is always going to be higher. And what Geoffrey Rose says is that if you want to improve the health of your population, what you should be focusing on is shifting the entire risk profile of your population to the left. And by doing so, you shift the burden of disease and you also reduce the amount of intervention that you need for your population. Because as you go to the right, The risk increases, but the level of intervention needed also increases. Whereas when you go to the left, you will still need some level of intervention, but the cost is much less. So basically, if you look at the high risk reduction approach, you're looking at short-term symptom management. If you're looking at the population approach, then you're looking at medium to long-term prevention and health promotion. And this is not just about public health and social determinants. You can think about this from your surgical lens as well. If you're looking at road traffic accidents or, like we mentioned, electrical burns, there will probably be other causes of incidence which is increasing the demand for surgical services within your population. And if you're able to reduce that demand, then you're going to be able to free up your limited resources to tackle some of the other things that you may not be able to address in a risk reduction approach, or in a population approach, sorry. And so now we've sort of come full circle, taking this thinking, how do we build a stronger society in COVID-19's aftermath? And you've probably, if you're reading the news, you've heard of these concepts of build back better and a green recovery, etc., etc. And here I'll introduce you to this concept of a quincunx. And so basically what this is, it's sort of like a toy where you have a funnel with a bunch of marbles at the top, and then you have a bunch of pins put on a wall. And underneath, you have different containers. And you let the marbles go through the quincunx, and what you'll find is that it creates a normal distribution every time. And so if we go back to Geoffrey Rose's teaching and designing and shifting normal distributions, and we look at these pins as comprising society's structural elements, whether that be house, jobs, education, transport, food, air, water. If we can modify these pins in such a way that they reduce the causes of suffering for your population, they reduce demand, for example, for surgical services, then you can shift your entire risk profile and you can create a new normal distribution of a healthier population. So this is the Geoffrey Rose curve again. So this is just, from the situation of fundamental uncertainty. If we took simple steps, we're actually positioning ourselves to improve the health of our populations. That's all, and if you have any questions, please feel free to email me, and I look forward to the discussion. Thank you.